My name is Nicola Longo, and I'm a professor of human genetics at the University of California, Los Angeles. I diagnose and treat patients with genetic disorders and with metabolic conditions, including phenylketonuria. Phenylketonuria has been the prototype of treatable metabolic disorder. In fact, it was the very first condition for which newborn screening was established starting in the 1960s. The reason that it was subjected to newborn screening is because early therapy can prevent intellectual disability. And that was the case. The therapy with a diet that it is severely restricted in phenylalanine was effective in preventing intellectual disability. What it is emerging, however, is the fact that it is difficult to keep the phenylalanine level within the recommended range. And while we can prevent intellectual disability, there can be other psychometric problems that emerge as people become older. What we are observing is that people who do not maintain phenylalanine level within the recommended range have an increased incidence of attention deficit disorder as children. And as they grow older, they tend to have increased incidence of psychiatric problems with mood disorder, anxiety, and depression. How do we prevent that from happening? So obviously, one can enforce the diet a little bit more, but it is difficult to enforce. The reason being that it is severely restricted in protein. What that means that many times people can go to the store and not find any food that it is low enough of protein for them to eat. They need to continue to use a special formula, which is like a special milk, like the one that we prepare for children, in which all the amino acids are present except phenylalanine. It is an artificial formula, and obviously it doesn't taste as well as regular food. And that it is why, as people grow older, there is progressive loss of compliance with the therapy because it becomes almost incompatible with a social life and with what most people do. So, and that it is why there is the need for new therapies for this condition. The first therapy that was developed is Sepiapterin. Sepiapterin is a synthetic form of tetrahydrobiopterin, which is a cofactor of the enzyme phenylalanine hydroxulase, the one that it is not functional in phenylketonuria. Tetrahydrobiopterin at high doses can improve the activity of certain mutant enzymes. Diet becomes progressively more difficult to maintain for individuals with phenylketonuria, and that it is why we have been looking at developing additional therapy that can help them maintain phenylalanine levels within the recommended range during the lifetime. Not every person responds to Sepiapterin, and only specific mutations do. Still, people who respond, they can liberalize their diet a little bit more and are more likely to maintain phenylalanine level within the recommended range. Again, the level of reduction of phenylalanine is limited, usually about 20–30% from baseline. And in addition, only a limited number of patients respond well, again, about 20–30% as well. The second therapy that has been approved is an enzyme substitution therapy, which consists of the injection of phenylalanine ammonia lyase. This is a bacterial enzyme that is able to digest phenylalanine and transform that in tranexamic acid and ammonia that are detoxified by the human body. This therapy can be very effective. However, we are administering by injection an enzyme that it is not physiologically present, for which there is a high risk of immune reaction. Some people respond very well to the enzyme and they can pretty much liberalize their diet. But many people do not, but they develop a reaction both in the site of injection and more generalized reaction that prevent them from continuing the therapy. And this leaves some unmet medical need for many of the individuals with phenylketonuria. So again, there are existing therapy, they work, but they do not work for everybody. And the second thing, the available oral therapy is only effective in a minority of patients with phenylketonuria. Given the medical need in the population of individuals with phenylketonuria, new therapies are being developed. One of them is sepiapterin. Sepiapterin is a natural precursor of tetrahydrobiopterin. What is the difference between sepiapterin and tetrahydrobiopterin? The big difference is that sepiapterin can cross membranes much more easily. What it means is that it is more easily absorbed and can penetrate inside cell more easily, including inside the liver, which is the organ that physiologically detoxifies phenylalanine. Initial trials have determined that by giving sepiapterin, there can be a reduction of about 60% on average of phenylalanine level in patients who respond to it. The latest clinical trial has done two things. Has demonstrated in a double-blind, placebo-controlled manner that it is indeed true. So there was a decline of phenylalanine level that was between 48 and 60% in patients who were responsive to this therapy. In addition, a larger amount of patients, including patients with classic phenylketonuria, responded to therapy with sepiapterin. Patients who responded had been not only defined as classic PKU based on the highest phenylalanine level that they ever recorded, like it is done clinically, but also by looking at their genotype, looking at the specific mutation causing their phenylketonuria. And again, even in them, the one who responded, there was about a 60% decrease in phenylalanine. Now, what does this mean in practical terms? What this means is that many patients who continued long-term therapy with sepiapterin were able to progressively liberalize their diet to reach a level of protein intake which is the recommended daily allowance. Many people in the United States and everywhere in the world eat way more than the recommended daily allowance. But just reaching that amount means that most people can go to a grocery store and find food that it is relatively low in protein that they can eat to satisfy their hunger and their desire of trying different things, meaning that this is a significant improvement in the quality of life of many individuals with phenylketonuria. Not everybody responds to the new drug, but many more people than before are responding to it and has the potential of really improving the quality of life above the existing therapy that are already FDA approved for phenylketonuria. And the good news for both individuals with phenylketonuria and the medical community is that we have an additional medicine that we can use in addition to the existing one. So as in many other diseases, sometimes we have different medicine and one patient might respond better to one rather than another. This gives us the opportunity to individualize therapy for each patient with phenylketonuria and making their quality of life the best that we can.